Thank you all. So now it's time for questions, and I'd like to encourage you to come up to this mic or that mic. Don't forget to give your name and organization. So to kick things off, because I'm hoping there will be questions from the group, I would like to ask each of our speakers, what impact, if any, will health reform have on the non-medical factors that affect poor health? Any of you? All of you? Some of you? One of you? Okay, go.
Well, I mean, for starters, the Affordable Care Act provisions in there is what has given us, for example, the CTG transformation grants, which require that health and non-health sectors work together to improve health. Another thing is also better integration of primary care and public health. So I think there are many opportunities inherent in healthcare reform to engage non-health sectors.
Steve?
I would echo that. I think there's a real need to educate the public and policymakers about the elements of the Affordable Care Act that embody the principles that we just heard about, the need for integration, getting across sectors, and the CTGs and other efforts like that are really built on that principle. Unfortunately, in the public eye, much of the focus is on the insurance reform, and a lot of the resources and policy issues are directed at that, but that additional element is key. The point I would make, which is not quite directed at your question, is that there is a tendency for people to feel like, well, we passed the Affordable Care Act, so we've addressed the health problem, and we need to understand that policy decisions on the table around other issues like education, the economy, and jobs, and economic development are also part of the holistic solution to health.
Picking up on that, if I could, that's a great point Steve just made. I would add that the integration of the insurance provisions with a broader awareness of public health implications and population health is kind of where the sweet spot is. And one specific example, which I think is going to get a lot of attention, the new rules for insurance allow employers to charge people more money if they smoke, and to give them a discount on the premium if they participate in a wellness program chosen by the employer. Simultaneously, the CDC is tasked with educating the employer community in general and the population at large about which kinds of wellness programs work. But the link between individual behavior on smoking, and no doubt some version of obesity is coming on that score, with the tools that are there to actually improve a person's and eventually the population's health, those tools are outside the healthcare system. As Steve said, they are fundamentally in the community and in the home. And so it is the awareness that insurance regulations will produce that should trigger a great deal of engagement of the tools that are both present in some places and developing in others.
Thank you. Okay, so this is probably a politically incorrect question, but having heard the presentations this morning, and some of us having some understanding of these issues before this morning, this seems sort of self-evident, like we ought to just do it. We're talking about Virginia. So what are the strategies that could be most effective to get this kind of information to the policymakers, besides Senator Barker, who actually get to make decisions on this, both at the local level and in Richmond? How do we do that?
Well, I think that the first step is just connecting the dots. It's not like, at least in the topics that I was covering in my presentation, it's not like people aren't already aware and interested in economic development, the jobs issues, education reform, and so forth. The insight here is making the connection between those policy decisions and health, and as I tried to clarify, healthcare costs. So I don't think that the typical policymaker is necessarily doing that kind of ROI calculation when they're thinking about the pros and cons on what to do with the education budget or jobs and so forth. The more obvious arguments for those policies are probably coming to mind, and lobbyists and advocates for those policies are probably pointing to the typical benefits of that. But as I tried to show with my calculations with our calculator and with other work that Bobby Milstein in those examples, and there are many more that those are selected from, we can do a better job of helping the policymakers see the economic benefits and how decisions made around those social policies will ultimately not only improve health for their constituents, but healthcare costs for businesses and governments.
Len?
You know, one of the fascinating things about dealing with employers in these conversations is how I would say the message is spreading, and indeed the awareness is spreading like wildfire, that for many employers, the largest cost of unhealthy workers is not what they spend on them in the healthcare system, but the productivity loss from absenteeism and presenteeism, which is when people show up but they're not really able to work. So the non-healthcare costs of lack of health have become a C-suite issue. I was just speaking, in fact, yesterday to a group of brokers who manage healthcare choices for large self-insured employers, and trust me, they are all over this. This is front and center. And so that awareness that it is indeed health and not health care that folks need to be focusing on is precisely driving the economic point Steve was making home at a very micro level, not even the macro economy of Virginia, but more precisely in my company, I'm losing too many days lost because I don't have a good mental health coverage. So fundamentally, I think that message is spreading. Our task, it seems to me, is to leverage that, if you will, budding awareness in the private sector and show the people in Richmond who might be inclined to think it's not an issue for the economy and for economic leaders. Maybe it's easier for them to hear that from the economic leaders rather than from those of us who do this for a living.
Interesting. Gloria, any comments?
Yeah, I mean, I think the economic argument that has been articulated is front and center and should be spread. One of the things that I find out, though, that I think happens quite a bit, though, is sometimes the feeling that, but this is already being done. I mean, what things are being done are good. And for those of you who've heard me say this before, it's almost like looking at that picture that you either see a pretty woman or an ugly old woman in that same picture. So the politicians, the employers and blah, 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 who are doing something think, oh, this is just the prettiest thing, since sliced bread. It must be working, we're on the right track. And then those of us who have connected the dots a little better and really understand the ramifications of social determinants and so on are saying, but it's not quite that. There's still an ugly woman in this picture, And for me, one of the things that needs to be done is for us to be able to show the two pictures in one. We're all looking at the same thing, but there is really the ugly picture, the pretty picture you're looking at, and there is an ugly picture, meaning that there's a whole lot that needs to be done. And I think that's the beginning of the conversation for moving all of us, including even our non-health sector partners, forward.
Great.
Can I make an additional point? I wanted to make an additional point, which is that I think there's sort of an elephant in the room, which is that some of the lack of motivation to address some of these problems, I think, comes from decision makers who have the sense that this is a problem for minority populations or the poor in isolated neighborhoods and so forth. But for the rest of our society, we're in a good place. And I just want to circle back to the report that I mentioned at the beginning of the talk that I was involved with, where we looked at the U.S. health disadvantage relative to other countries. What we did in our analysis is we actually analyzed health of Americans who are advantaged compared to Americans or compared to people in other countries. So if you look at well-educated, college-educated Americans, non-Hispanic white Americans, insured Americans, upper-income Americans, and compare them to people in other countries also with upper incomes and educations and so forth, Americans are dying younger. American children are dying younger than the other children. And what it speaks to is a systemic problem in our country. It's an environmental problem that is not restricted to minorities or the poor. Clearly, there are greater health disparities and more acute problems in those populations. But we as a society, we're all in this together, and addressing these broader determinants of health is something that we all would benefit from, because as a society, we're not as healthy as our counterparts in other countries.
I'm encouraging questions, and I come up to the mic. You can like make a little line. Would you give your name and organization, please?
I think it's on now.
Yeah.
Yeah. Ernie Haywood, chair of the board of the Health Foundation, Northern Virginia Health Foundation. I'm wondering, is there a way that we could perhaps package the message to policymakers a little bit better? And in that light, what role can you see the nonprofit sector, and what role do you see philanthropy playing in this whole equation, broaden the socioeconomics of health? Is there a broader role, both in terms of packaging the message, but delivering things in the community for those sectors and perhaps even other sectors?
I love the question because I'm a passionate believer that that's where we need to go. I think the facts are in hand, all the numbers and data, we all understand this issue, and the big challenge now is communication, is how to frame it in a way that is compelling. And I like Gloria's point about helping people to see how this fits into meeting people where they're at. And so the people that we're trying to persuade, whether it's politicians or CEOs or health plans and so forth, of framing the message in an effective way for them. And I think some of the most exciting work that's going on in public health and in social justice issues is around how to recast the argument in a way that resonates and isn't a turn-off, and people see where there's a benefit for them. So I think we in public health need to do more in terms of collaborating with our colleagues in communication science and advertising and social marketing and so forth to be better communicators of our message.
Hello, my name is Dr. Grace Keenan. I am the CEO of Nova Medical Group and Urgent Care Center in Northern Virginia. So we have 4 locations, and we practice primary care and urgent care. I'd like to thank you for your presentation today, and Dr. Gloria, I particularly appreciated your points about the community being involved. I don't think that this issue, which is just paralyzing our country, is going to be solved by the medical profession alone. And I think that the church, faith-based community is going to be probably a leader in this, and I appreciate you bringing that up. And for those who are interested, you could look at the Daniel Project. You can Google it, but it's an example of a church-based effort that was quite successful. The evangelist Rick Warren in California had his followers engaged in this. I think Rick himself lost 150 pounds. My understanding of that project, and you can look it up, but 15,000 people in that church community partook in this. In 1 year, they lost 250,000 pounds, and my understanding, it's continued, and they've now lost 500,000 pounds. Some of the drug regimens today are costing more than $100,000 a year per patient. So we are not going to be able to fix this by just throwing more money at more drugs and making sure that everyone has an HMG-CoA reductase inhibitor, and on and on and on. And we have the research, it's there, but it's not marketed because there's no money in it, to show that diet, exercise, and lifestyle will give the same reductions in cardiac events as all these drugs. And so 70% of our healthcare costs today are from chronic disease. We can't fix it with just all these drugs. This is breaking our back. And the other thing is that when you mentioned primary care physicians and working with the medical community, most of these government-sponsored plans pay between 20 and 25% of what is billed. Doctors' overhead is 65%. In the next 5 years, 25% of the primary care doctors in this country are retiring. And many more are getting out and fleeing because of the incredible regulation that is now being imposed on physicians. And you can become a criminal without, even ever having any kind of intent, just because of all these regulations. So somehow we've got to come together. I see there's a lot of R's on the documents of who's going to be making the decisions that you've shown us for the Senate and House for Virginia, and there's a lot of D's here today. And I think what we all need is we need the D's and R's to come together and stop pointing fingers at each other. And we have a real issue, but we have to be productive as a country. We can't break the back of all the businesses carrying this load and then also forget the needs of our people. So it's an effort we all have to come together. Thank you.
Thank you.
Very nice.
Hi, I'm Basim Khan, a primary care physician at Alexandria Neighborhood Health Services, a local community health center here.
Dr. Khan, you need to say it again because I don't think people heard you.
I'm a primary care physician at a local community health center. My question is about what potential do you see for ACOs or similar integrated models of delivering care for venturing more into public health, at least as compared to the entities within our more fragmented system. Just wanted to hear your thoughts about what the possibility of that happening is, particularly in our area here.
Len?
Well, I think the ACO construct, one in which there's integration, at least clinically, between hospital, physician, and some maybe post-acute care people in facilities, is a good place to start. I think the question, though, which is a perfect one, is who really cares about people who are not covered in an ACO context? Typically what's going on is the ACOs are really new ways of organizing payment and hopefully delivery of care, as well as teaching patients how to manage themselves, but typically around patients that have a particular insurance card. So the question is, will someone, to be crass about it, incentivize institutions, be it ACOs or for that matter, integrated hospitals that are not full ACOs but have outpatient clinics and primary care clinics? Will somebody incentivize them to really engage in population health? And I think that's where the collaboration that we just heard quite eloquently presented by the woman who, in my view, should run for State House, that kind of collaboration is exactly what it's going to take to get us to that promised land. But at the moment, the payment reform endeavors that are coming out of CMS, from the ACA, and virtually everything that's being done at the local and state levels is all focused on specific populations, Medicare, Medicaid, or maybe commercial insurance, but very few are engaging the uninsured. It is possible to work them into some of the experiments, but at the end of the day, somebody's got to be willing to pay for them for that to work.
Thank you. Other comments? Nancy?
Thank you, Pat. My name is Nancy Pallison. I work for the Arlington Free Clinic. And my question really focuses back on spreading the risk in healthcare reform, and I'd like to hear from our experts this morning, specifically regarding the exchanges. When I have an opportunity to talk with young folks, the healthy young folks, the healthy, non-vulnerable young folks, and invincible young people who say they're not going to get into the exchange, they're not going to buy insurance. They don't need to, they're healthy, they're not going to get sick. So if, in fact, what is your assessment of whether or not enough young people will buy into the exchanges to spread the risk enough to make the insurance companies stay in the game viably? I know there's some concern, talking with a couple of insurance people I know, about whether that's going to be possible or not. So I do also know very recently from talking with one of the volunteers in our organization who works on a contract. She actually runs a contract with CMS about developing education specifically geared toward these young invincibles across the country. So I know there is a lot of concern, but has anyone in Virginia taken a look at what might happen if enough people don't sign up? That's my question.
Len?
Well, I can assure you that a lot of people worry about this question, starting with the actuaries who have to produce the premium bids for the insurers, because they basically have to make a very explicit assumption about what the risk pool will be like. If you are following the revelation of premiums around the country, you will see that California just released their premiums in their exchange, and of the, I believe, 13 different insurers who were frankly allowed to continue to offer in their exchange, the premiums came in quite reasonable, way lower than a lot of people had expected. And those actuaries basically are betting that the risk pool there will be balanced, so enough young people and healthy people will show up and to balance out those who we know need care desperately and will come as well. Of the 13, there were 20 more that bid higher, and the active purchaser model of the exchange in California excluded them from being able to participate. So I think it's fair to say that suggests to me as an economist there's a difference of opinion about how many healthy people will show up in California, and by constraining the market to be just the lower bids, they're trying as hard as they can, the people running the exchange there, to make the premiums low, to make it more likely, more attractive to the young to buy. Two things I would point out in terms of fear and reality. One is most people have insurance today, and most people who have insurance today are healthy. Of the people who don't have insurance, turns out on a normal day, most of them are healthy too. There are some quite sick people who need care, but as you put out, there are a lot of fairly healthy uninsured as well. The reason for the purchase requirement, or so-called individual mandate, was because insurers and anybody who understands the market understands you need everyone in to make the risk pool balanced. The problem in the law from a technical point of view, from an actuarial point of view, is the penalty for not purchasing is so low in the first year, $95. It goes up to 2% of income in a couple of years, but that's still going to be quite a bit lower than what it would cost to buy a policy if you're buying a policy unsubsidized. The counter to that in the law as it was promulgated is if you're low income, you should get a hefty subsidy to buy your insurance, so the amount out of pocket for you, and particularly for some of those young immortals, may not be all that much. That's a long way of saying there's a lot of uncertainty here. No one knows for sure. Actuaries have to make the bet. When the what I call outreach advertising starts, which apparently will start to unfold in July and August of this year, at least the federal effort, And the federal effort will be relevant for Virginia because we have a federally run exchange and not a state-run exchange. There you will see, I believe, a lot of targeting to the young and healthy, pointing out the advantages of buying insurance and the disadvantages of not. But, and I do think there'll be a fair bit of outreach, possibly funded by other sources inside Virginia as well. People are talking about that in Richmond and elsewhere. But you're right, it's a major issue. We don't know for sure. The one example we do have in Massachusetts is that in the individual market, actually, after their mandate went into effect, and their penalty, by the way, was even lower than the federal penalties in the first year, they had 97% of their population show up, and the individual market premiums actually went down from where they had been in the pre-reform world. So it is possible to get a balanced risk pool. I will point out the Massachusetts example, they did a lot of very effective outreach, far more than we've been able to do as a nation in this case.
Thanks.
Thank you, Pat.
Sir?
Hi, Tom Prohaska here, Dean of Health and Human Services at George Mason University. Hey, Len. I had a question or a concern. I'm brand new here to Virginia, but I've been doing national consulting in the area of policy and public health for 30 years now. And the concern is I recently just received an alert that RAND will be coming out with a report to the ACA talking about the modest effects of mutability of behavioral risk factors. And this gets to the heart of the matter what Gloria and I think Stephen are getting at, that when they look at the top of the pyramid and look at counseling and education, that they think that that is the wherewithal of where all behavioral risk factor interventions are occurring. And corporate wellness is notorious for not having evidence-based programs in the first place, and they very rarely look upstream when it comes to the nature of the intervention. So do we have a response for this and similar other kinds of reports that could be coming out that could undermine the potential of promoting health promotion?
Could you, I had a little trouble hearing you at the beginning. What did the report say?
The report is not out yet. I got a public health alert when reports are about to come out that are contrary to what we should understand is the truth. And this report is saying that corporate wellness interventions for health promotion are modest at best. Depending on how they package that and interpret it, it could lead to a backwards trend towards saying these things don't work. We understand that they do, but it's much more complex than the just top of the pyramid of health education and counseling. That was my point.
Well, I mean, there's a large literature on this, so it'll be interesting when the report comes out to understand how they're making sense of the evidence, because there's a large body of evidence about the effectiveness of worksite health promotion programs. But I think your larger point is that if we are only looking at the top of the pyramid, we're always going to see more marginal impacts on health outcomes than these more holistic approaches. That really circles back to the point that was made earlier by the CEO of the primary care system, that the notion, I mean, when I was in training, you know, the advice was, we have a problem with smoking, doctors should counsel their patients to stop smoking. And if Johnny's overweight, tell the parents that he needs to eat more fruits and vegetables and exercise outside. And now, as Gloria was saying, we've moved beyond that to understand that we have to realize that Johnny's going home to a neighborhood where there's no place to exercise and there's a food desert and there's no way to eat the fruits and vegetables because you can't purchase it and so forth. So we really have to promote that larger awareness of how our health is shaped by our environment, and that otherwise we're only going to get marginal effects on health outcomes.
And I think to add to that, as we move towards that bottom part of the triangle message, we shouldn't then neglect the top half, because you could have all the vegetables in your neighborhood, and I have done that before. Sometimes you just walk straight towards the French fries. You know, it is an individual choice in the end. So that message has to be together. That triangle works together. So the clinical interventions have great impact if, when you go into your community, you're able to do all these other things. And sometimes one, goes against the other. it sometimes makes me cringe as we move towards healthcare reform that then the prevention funds get raided. I mean, it's almost as if we're getting the cards, and so the beautiful flowers coming along and everyone will be healthy. Well, it won't happen if the prevention fund keeps getting drained. The same approach happened, I remember, in Africa with HIV prevention, for example. So for the longest time, we had no meds, no medications for HIV. There's a lot of noise. Pharmaceutical companies and the world rallied together. People started getting care. Well, then the prevention message stopped. Well, people are, so the both have to go together to really make good public health impact.
Thank you. Gonzalo?
Hi, my name is Gonzalo Paz-Oldan, and I work at the Arlington Pediatric Center. And two comments. One actually ties in with what was just mentioned, and it's the importance of being patient-centered. We have been patient-centered in our practice, I think, for 11 years, but we're still not quite there. It's very, very difficult to do. For people like me that trained several years ago, I have to forget a lot about my training in terms of how I approach the patient and letting the patient set the agenda at the visit, which we're usually not trained on. I'm glad to see people like Dr. Wolf involved in medical education, but I think we need to talk about how we train our doctors and our future doctors. And I think it also requires that coordination of resources at the census tract level and neighborhood level. Many times we're duplicating services, and even though we think we're patient-centered, we're not communicating with other 5 organizations that are involved with that family. So we need to have that really data at the granular level where we practice. And as a pediatrician, I think I would like to emphasize the importance of investments in early childhood. There's very clear data now about toxic stress in early childhood and its effect on health and well-being, and adult health and well-being, and chronic illness. The substance abuse we have mentioned, the obesity, the diabetes, cardiovascular health. I'm very happy to report that the American Academy of Pediatrics, that represents over 60,000 pediatricians, has made this year childhood poverty one of their strategic priorities for the first time. And as we know, we have a lot to do in terms of childhood poverty in this country and its effects. And in terms of the messaging and packaging the messaging and early childhood, I think, for example, when we talk about access to quality daycare and access to quality preschool, we know that the return of investment of those things is huge in terms of the dollar you invest now and the savings you have down the line, but we have to wait several years to see those savings, but I think we need to be talking about those things too.
Thank you. Yes.
Good morning. I'm Jesse Ellis. I work with Fairfax County Executive's Office. And several of you have mentioned the importance of outreach and communication and getting people enrolled in insurance through the exchanges. And quite a number of us in the room right now have been working to try and identify a viable way to implement a navigator program with such little funding. And that brings up the real distinct difference between federally run and state-run exchanges. And so, Dr. Nichols, my question for you is, what do you see as the prospects of Virginia moving into a state-run exchange from a federally run exchange? And I know you can't see me, but I did an exaggerated wink when I said federally run.
Well, I appreciate the wink. I would say it this way. This is a big country, right? Roughly half the states are going to let the feds do this. Roughly half the states are going to try to do some version of it themselves, and a few are going to do this partnership business. everybody's going to be watching everybody else. So I like to take us back to when Medicaid started. In 1965, you recall, Medicaid was tacked on to Medicare at the very end. And basically, the first year of Medicaid was 1966, and essentially the federal government said, whatever you're doing for the poor, and at that time everybody did something, whatever you're doing for the poor, we'll pay half, and then we'll figure out what to do later. And basically, 26 states took up the federal government offer to pay half of what they were doing the first year. It took 4 years before we had 49. Virginia was in that fourth year, 69. And Arizona didn't take it up until 1982, and I noticed they still don't have daylight savings time. It's a big country, and we move at different speeds. So the prospect of Virginia adopting their own, remember the Advisory Council, which is a group picked by the governor, so it leaned to the right, and on balance, that group concluded we needed to do our own exchange, I'm not kidding, in 5 minutes. They did not want federal takeover. We don't have our own exchange because, frankly, politics and calculations that are beyond this year or this conversation. I do think a lot of people want to run it themselves. Certainly the state insurance people would like to have state control. I think, though, the reality is now, people will watch how it works elsewhere. If other states are seen to be better than we are, then I think it will happen quicker in Virginia. The elections matter a lot, but I think performance elsewhere ultimately will determine whether we adopt it and how soon.
Thank you.
Hello, my name is Lisa Aneva. I'm with FitLoose Health and Fitness. And this is kind of a broad question, but we're talking about resources that are being spent on people's health, whether it's public resources or their own personal resources, and the idea possibly of making changes so that maybe less resources are spent so that people are healthier. And I was just wondering, since there's such a wealth of knowledge on our panel, people are always interested in results. And if you all on the panel had identified any groups or possibly segments of the population that would have what I would call maybe good conversion potential, so that you target programs at those specific groups, and you can see results, and then possibly it frees up resources for other people who might need those resources.
Interesting question.
I think there's a large effort going on in that regard. One quick example that I think comes to mind is the diabetes prevention program, which is based on research showing that if you take people who are at risk for diabetes, who have pre-diabetes, and help them engage in intense physical activity and dietary changes, you can reduce the prevalence or the incidence of diabetes by 50%. And that tremendous reduction in the risk of diabetes, which is a major driver of healthcare costs, has led to a whole national initiative. The YMCA is involved and other collaborators, United Health, in communities all around the country trying to implement that program. So it's an attempt to improve health outcomes, and that obviously does free up resources for other needs. Is that the kind of thing you mean? Okay.
Great, thank you. This is the last question.
Hi, I'll try to be short and concise. I'm Cecilia Vergaretti, and I'm the Senior Director of the Capital Area Food Bank in Lorton, Virginia. And we're seeing exciting things happen. We have a new CEO, Nancy Roman. She has international experience with the whole hunger paradigm. And so in putting forth our strategic plan, this conference came at such a great time, because one of our focuses is having these partnerships in non-traditional food bank ways, so not just with our food pantries. And we're really looking at indexing our inventory, low sodium. Half of our distribution is fresh produce. And in particular, we're trying to market this thing called family markets, which would be a place where families could come and get high quality, high content, nutritious food, but we would have some add-on value like nutrition ed, etc. And it would be food that if they had to go to a food pantry, it would be the type of food they would get at a food pantry. So we're not talking about recipes from Bon Appetit, we're talking about real food that they would get. So our part would be access and education. But in being here and thinking about all this, we were thinking about doing this in schools, but now my brain is spinning and I'm like, we could do this at healthcare clinics, you know, we could work with primary care physicians. And so I just wanted to express my thanks because I'm going to go back and talk about this conference and make sure we show all of the slides and get everybody pumped up, and you will be hearing from us because this is awesome.
What a nice way to end this. Thank you. I'd like to ask that you give our speakers one last round of applause. Thank you all, and Len, especially thank you because I know it is really early where you are. So I appreciate it. Thank you.
That'll do it, Pat. Take care.
You too. I'd now like to bring up to the stage my friend, Andy Burness. He's a local and national leader who has worked to communicate health issues to the public for more than 25 years. Andy will give you pointers about the discussion you're about to have.